It's going to be difficult for me to maintain your attention after this excellent film, but I'm trying to do my best. I was asked to present the subject, anesthesia for cesarean delivery. What do the obstetrician have to pay attention to? And I have summarized the points that the obstetricians have to pay attention to in 6 things that you see there. Category of urgency for C-section, prevent maternal hypotension, regional versus general anesthesia, prevent Mendelssohn syndrome, aspiration of gastric content, drugs and techniques used, postoperative tuberculosis prevention. And we'll start with category of urgency. Since Lucas publication in 2000, urgency of cesarean section is classified by anesthesiologists into 4 categories. Category 1 is immediate threat to life of women or fetus. Category 2, no immediate threat to life of women or fetus. Category 3 requires early delivery, but all the first 3 of them include maternal or fetal compromise. When there is no maternal or fetal compromise, there is a coordinated cesarean section, and at a time to suit the woman for maternity service is category 4. So this is known by most obstetrical anesthesiologists, and I have the pleasure of working always with obstetrical anesthesiologists that manage the situations perfectly well. In cases of urgency, all of you know that in cases of fetal hypoxia during labor, we can delay a little bit the cesarean section to allow the fetus to recover into uterus by using acute thrombolysis, as has been clearly demonstrated. The main point to see is the decision, moment of decision, to the time of delivery, and this depends on many factors. In my hospital, in which we have at least 3 or 4 anesthesiologists inside the hospital in 24 hours, we are able to keep this time as low as 10 minutes between the decision and the cesarean section. But in most cases, the time is longer because the anesthesiologist may be out of the hospital and we have to call him to get in the hospital. Royal College of Obstetricians and Gynecologists in 2010 have discussed 15 minutes to be ideal, 16 to 75 to be in the middle, but no doubt that more than 75 minutes you will get lower than 7 Apgar scores and increased maternal and fetal complications. My friend Tai Leung from China has published recently a study on timing of cesarean section according to urgency, and he suggests that the limit time should be no more than 30 minutes. Because he has shown that when there is fetal bradycardia, even if it's irreversible or potentially irreversible or of unknown origin, the arterial cord pH decreases 0.011 per minute that you delay the fetal delivery. The second point is prevent maternal hypotension, and this we have to take very good care of, because most anesthesiologists, mostly those who do not work usually with obstetricians, do not take care of this point that is very important for the fetus. The fetus reacts very rapidly to maternal hypotension and can go to hypoxia and acidosis. So it's very important, first, that the transfer should be done with the mother in a lateral recumbent position to the operating room, as you can see there. even if it's a non-urgency operation, and this has to be taken into account mostly in general hospitals in which there are anesthesiologists that perform a lot of anesthesias, not only obstetricals, because most time the people that transfer the mother to the operating room tell her to lie her on her back. And you know that this can produce maternal hypertension. The anesthesiologist should be ideally with the patient all the time of the transfer, and prehydration should be performed before the cesarean, together with a new concept which is called co-hydration, which is done mainly with colloids to prevent hypertension. This hypertension, as you may know, is more frequent in elective cesarean sections, in obese patients, and in twins. At the operating room, in the operating table, the mother has to be tilted 15 degrees at least to avoid inferior vena cava compression. And although this is a little bit more difficult for the surgeon, it is of utmost importance for the fetus to deliver without maternal hypotension. You can treat hypertension by what is called pharmacological sympathectomy through the administration of phenylephrine, ephedrine, or etilephrine, being the drug of choice, phenylephrine intravenously. This produces a pharmacological sympathectomy, and you should not start your surgery unless you have an abruption placenta or a cord prolapse until you have recovered the maternal hypertension so that the fetus is born in a good condition. This study by me to prevent prevention of maternal hypertension after regional anesthesia for cesarean section concludes that recent research supports decreased use of crystalloids, prehydration, and ephedrine, and increased use of co-hydration, which means hydration during the procedure, with colloids which are smaller, with smaller spinal doses and phenylephrine. Regional versus general anesthesia. No doubt that regional anesthesia for cesarean section is safer for the mother and the fetus. We have less maternal and neonatal morbidity, and this is an evidence type A, so it's completely, no doubt we have to prefer regional anesthesia in case it is needed. General anesthesia then should be performed only when the mother has spinal pathology that contraindicates regional anesthesia, for example, an infection on the site of the puncture, or some problems with the spine, when there is regional anesthesia failure, and of course if we have a mother with convulsions because of an eclampsia. In that case, we should use a general anesthesia. The fourth point is prevent Mendelssohn syndrome. Mendelssohn syndrome, as you know, has been described firstly in a cesarean section in 1946 by Curtis Mendelssohn. It is more frequent in pregnant than non-pregnant women due to mainly elevation of diaphragm, because also intubation is more difficult in the pregnant patient because of edema of the glottis and the epiglottis. And you need, for prevention of Mendelssohn syndrome, 8 hours fast, not 6, 8 hours fast. And there's one thing that most times obstetricians do not take into account. To prevent Mendelssohn syndrome, it is highly recommendation. It's a high recommendation to premedicate the patient with sodium citrate or peros, ranitidine intravenous, or omeprazole to reduce acidity of the stomach. Situation that every anesthetist looks at like a catastrophic event during general anesthesia is no intubation, failure to intubate the patient, failure to ventilate the patient. Unfortunately, in the last years, the laryngeal mask has been invented to act in these cases. But this is a nightmare for the obstetrician and also for the anesthesiologist and also for the obstetrician. The drugs and the techniques used. The techniques used by anesthesiologists are top-up epidural in case of cesarean section during labor. That means to increase the level of anesthesia, increasing the dose of drugs used. Spinal anesthesia, which is very fast, or general, which I've been talked already about. When there is a top-up, when there is labor going on with epidural anesthesia, there's the chance of decreasing the doses versus maintaining equal. Decrease spinal dose in case there is already an epidural, means decreasing the dose of bupivacaine. Add opiates, the opiate of election is fentanyl, and then you have the dose. And have the mother to be sitting for 2 minutes before starting the surgical procedure. If more than 30 minutes have passed after the last epidural dose and no blockage of initial dose persists, then you have to use the usual dosage. The epidural top-up in combined spinal and epidural anesthesia includes lidocaine, 2%, adrenaline to reduce the absorption of lidocaine to the circulation, fentanyl, and this top-up has to be given half in the delivery room and the rest half in the operating theater. The epidural top-up has to be done with 0.5 milligrams of bupivacaine and 2% of lidocaine plus adrenaline in 1 in 200,000 fresh, which means it has to be prepared in the moment, because the exposition to the light decreases the effect of adrenaline. There are several randomized trials which show same results, but lidocaine is less toxic and cheaper than bupivacaine. There's a technique that is called fast spinal anesthesia, which gives appropriate anesthesia level in 6 to 8 minutes, which requires one thing that is very important, that the obstetrician, the surgeon, does not touch the patient while the drugs are making the effect, because otherwise you will need more time. No use of opioids, using only bupivacaine up to 12.5 milligrams, and do no more than 2 intents to reach the spinal space by puncture. If you fail to reach, the anesthesiologist fails to reach the spinal space after 2 punctures, then you must switch to general anesthesia. So you have to be prepared for general anesthesia if the level is inadequate. There are known risk factors for failed convention of labor epidural analgesia to cesarean delivery anesthesia. There is number of policies. The odds ratio is 3.2 as the number of policies increase. The urgency odds ratio increases by 40 if you have to converse from epidural for delivery for cesarean anesthesia. And there, as I told you, the importance that the anesthesiologist has a special preparation in obstetrical anesthesia, which is the anesthesiologist is a non-obstetrical anesthesiologist. The odds ratio of failed conversion increases by 4.6 times. The spinal dose and the coadjuvants are related to more pain, more need of complementary medication, and more needs of general anesthesia. It has to be documented. The sensory level needs to be is best evaluated by the anesthesiologist rather than the surgeon. So I advise you not to clip maternal skin before the anesthesiologist says, go ahead, because otherwise you might end in a general anesthesia. For nausea and vomit prevention, Mendel's syndrome, as I said, you must always give sodium citrate per os, ranitidine or omeprazole, and ondansetron intravenously to prevent this catastrophic event. Finally, one thing that we obstetricians often forget, maternal coagulation system is increased during pregnancy and postpartum, so we have no doubt, there's no doubt about this, but use adequate prevention of postoperative thrombosis, so always to prevent thromboembolism due to thrombosis in anticoagulants. The best choice is low molecular weight heparinoids, 12 hours after surgery, and advise the mother to a precocious embolization. Finally, I would like to remind you and invite you to FIGO Vancouver in October 2015, and thank you very much for your attention.
Thank you, Justus. Let's leave the discussion for the end, and I will invite José Palacio to give the lecture, Cesarean.